To open the next session, please welcome Dr. Gracieux Fernando, AOS Council Member, Chair of the Philippine Specialty Board of Medical Oncology, and past President of the Philippine Society of Medical Oncology.
Good evening, ladies and gentlemen. I am Dr. Gracieux Fernando, your session chair, and welcome to the AOS Convention session on soft tissue sarcoma. Sarcomas are rare tumors that oncologists hardly see in their daily clinical practice. We hope that the following sessions will give you the necessary information to help you deal with these conditions. Our first presentation is the surgical management of soft tissue sarcomas, presented by Professor Edward Wang, recipient of the Dr. Johnny Escandor Professorial Chair Award at the UP Manila College of Medicine, Philippines. Dr. Wang is a professor of orthopedics, a university scientist, the lead of the UP Manila College of Medicine Surgical Innovation and Biotech Lab and Skill Lab program, the chair of the Committee on Research Integrity, and the member of the UP Manila Research Executive Council, the East Asian Musculoskeletal Oncology Research Group, the International Advisory Board of the Asia Pacific Musculoskeletal Tumor Society, and the International Society of Limb Salvage. Our second presentation is new developments in the systemic therapy of soft tissue sarcomas, presented by Dr. Tom Wei Wu Chen, an attending physician at the Department of Oncology of National Taiwan University Hospital. Dr. Chen is a member of the sarcoma multidisciplinary team at the National Taiwan University Hospital, the breast cancer multidisciplinary team, the Asia Sarcoma Consortium, the American Society of Oncology, the Connective Tissue Oncology Society, the Taiwan Oncology Society, the Taiwan Society of Internal Medicine, and the Breast Cancer Society of Taiwan. Our third presentation is immunotherapy in the management of soft tissue sarcoma, presented by Dr. Herbert Loong, an assistant professor at the Department of Clinical Oncology and Deputy Medical Director of the Phase 1 Clinical Trial Center at Chinese University of Hong Kong. He completed a fellowship program in drug development at Princess Margaret Cancer Center in Toronto, Canada, with special focus on experimental therapeutics, sarcoma medical oncology, and neuro-oncology.
Good evening, everyone, and congratulations to the Asian Oncology Society for a successful convention. Thank you specifically to Professor Emeritus Corang Elangel for inviting me to give this talk on surgery for soft tissue sarcoma, which I have limited to the extremities and superficial trunk. I take this opportunity to recognize my associate, Dr. Carla Araneta, for all the hard work that she's put in during this COVID time to the evaluation of the outcomes of our soft tissue sarcoma patients. These are my disclosures. Importantly, the information upon which I base this talk tonight is in large part drawn from 25 years of experience in both my personal clinics and in my work at the University of the Philippines Musculoskeletal Tumor Unit, which we started at the same time. This is a short outline of my talk tonight. We will be reviewing some general principles of soft tissue sarcoma treatment, followed by two workup issues that I'd like to talk about related to surgery. Then we'll try to define surgical margins, the role of amputation, radiation therapy, and take a look at surgical recommendations for different stages of soft tissue sarcoma. What is the role of lymphadenectomy? And what do we do with unresectable disease? And we finally end by a short discussion on inadvertent excisions or WOOP surgeries. So while we all agree that surgery probably remains the cornerstone of soft tissue sarcoma treatment, we cannot overemphasize the importance of referrals to sarcoma specialty centers. We cannot overemphasize the need for multidisciplinary team approach and the clinical benefits that are derived from treatment that is adherent to guidelines as espoused by cancer institutes and societies from around the world. Now, the preferred method of imaging is MR with contrast, and we recommend that an image of the entire region of interest be taken, and these images be reviewed by the surgeon and the radiologist prior to any kind of definitive treatment. Good quality MR studies will give you an idea not just of tumor location and size, but of the content and the contiguity to nearby structures and neurovascular landmarks. Here in the bottom two pictures, you will see clearly the distinction between MR and CT. And these are both images taken of the same patient, albeit maybe through different planes of the thigh, but you see clearly the superiority of the MR over CT in distinguishing between the different anatomic structures. Now, a quick word about biopsy. We recommend closed core or open biopsies, but we do not recommend the FNAB or fine needle aspiration biopsies, especially for sarcoma pathology. Another thing that we'd like to emphasize is the placement of the biopsy. These should always be in the line of the eventual incision, especially for limb salvage surgeries. Now, what are the staging systems most commonly used for soft tissue sarcoma? Of course, you first have the AJCC system, and then you also have the Enneking system, which has been adopted by the American Musculoskeletal Tumor Society and which we as orthopedic oncologists use more often. The AJCC system uses the T. In this case, it looks at size, 5 cm, more than 5, 5 to 10, 10 to 15 and above, the N, the M, and the grade or the G. In the Enneking system, you also have the T, but the T here doesn't refer to size, it refers to compartment. Compartment being predefined regions in the anatomy of a person. So you may have the anterior compartment of the thigh, then you have the posterior compartment, mainly referring to the hamstrings, and then the entire femur is one compartment also. Of course, you also still have the G, low or high grade, but the N and the distant mets are put under M. So both nodal and distant mets are under the classification of M. Now, what is the goal of surgery? The primary goal, of course, is to eradicate tumor. The secondary goal being to minimize local recurrence and other morbidities and to maximize postoperative function, whether this is amputation or limb salvage surgery. Now, in order for us to understand surgery, we need to define surgical margins. And there are 4 surgical margins we talk about, these being intralesional, marginal, wide, or radical. And this is true for both limb salvage surgery and amputation. The surgical principles remain the same. Now, on your left-hand side, you have a diagram which shows you tumor being the big red circle. Around it, you have a black line which represents the capsule. And then you have a yellow zone, which we call the reactive zone. And then the entire tumor mass is within, which is green. Now, take note of the red satellite nodules within the reactive zone and the skip nodule or skip metastasis within the entire compartment. These have implications in management of soft tissue sarcomas. So, an intralesional margin is when you remove the tumor from within the capsule. Now, that obviously leaves macroscopic tumor behind and is obviously inadequate for sarcoma surgery. An example of an intralesional margin is an open biopsy or debulking surgeries, which we as orthopedic oncologists very rarely do. What's a marginal margin? A marginal margin is achieved when you remove the tumor through the pericapsular reactive zone. That leaves satellite nodules behind. and it is therefore usually inadequate for sarcomas. An example of these being shell-out procedures. Now let's take a look at wide margins. These are achieved when the tumor is removed from with the surrounding cuff of normal tissue. You remove tumor and you remove satellite nodules, and this is obviously adequate for sarcomas except in those situations where you have skip lesions. A radical margin removes the entire involved compartment. This removes tumor, satellite nodules, and skip nodules. It's obviously adequate for sarcomas, but is very often associated with amputations or more mutilating procedures. Now, let's try to associate the margins with what we see on magnetic resonance imaging. So an intralesional margin is if you go through the tumor. A marginal margin is if you cut just outside the tumor through the pericapsular area. A wide margin is when you have a cuff of normal tissue. And a radical margin is if you remove the entire compartment. Now, let's take a look at the microscopic correlation. This is a low power picture, and here you have tumor, you have the capsule, and you have normal tissue. So if you go intralesional, that means you go through tumor. If you go marginal, that means you cut through the capsule or just around the capsule. And if you go wide, that means you go through normal tissue. Now, obviously, when you go in the tumor or when you cut just around the tumor or around the capsule, you will be encountering either macroscopic tumor or microscopic satellite nodules. So an incision through the tumor or through the capsule will obviously result in what we call positive surgical margins. And what's the significance of this? A positive surgical margin is a strong predictor of local recurrence. And two classic studies showed that positive surgical margins were associated with higher rates of local recurrence and a lower rate of disease-free survival. The 10-year possibility of local recurrence was significantly higher for patients with positive surgical margins. So why don't we just provide amputation for everyone? This was in fact standard of care until the 1970s to the 80s, until these two classic studies showed that limb salvage surgery with radiotherapy in one study was effective for patients with high-grade soft tissue sarcomas, resulting actually in overall survival and disease-free survival, which was equal to or better than amputation at that time. In the other classic study, it showed limb salvage surgery without radiotherapy, and there was a 0% local recurrence rate when the resection margins were more than 1 centimeter. So amputations today are reserved for cases in which appropriate resection margins cannot be achieved without sacrificing functional outcome. So in this patient with a high-grade soft tissue sarcoma of the upper extremity, which was abutting not only the humerus, but abutting and maybe enveloping even the neurovascular tissues here, the structures here, and not responding at all to chemotherapy or radiation therapy. So he ended up with a shoulder dysarticulation. However, we caution that patients should be evaluated by surgeons with expertise in the treatment of soft tissue sarcoma prior to being offered amputations. Is there a role for radiation therapy? Data supports the use of external beam radiotherapy, but radiotherapy is not a substitute for definitive surgical resection with negative margins, and re-resection to negative margins is preferable. So what are the surgical recommendations? Let's take a quick look at these. First, you have the stage 1, the smaller low-grade lesions. Here, recommendation is a wide resection if margins of more than 1 to 2 cm can be achieved, or if you can achieve a good fascial plane, an intact good fascial plane. Now, on the rare occasion, this is an exception, the atypical lipomatous tumor or the well-differentiated liposarcoma can be removed and blocked with simply marginal margins. Now, what about higher grade lesions? In those which are smaller, or the T1 lesions, the surgery alone for small tumors which are resectable with wide surgical margins is the recommendation. Or in those where you may not be able to achieve as good a margin as you want, you can give radiotherapy, as long as it is resectable with acceptable functional outcomes. What about in larger lesions? Again, the same, resectable with acceptable functional outcome, meaning maybe if your margins are just a bit closer, but you can resect with acceptable functional outcomes, you can resect with radiotherapy and with or without post-op chemotherapy. Now, the question is always asked, is pre-op better than post-op, or is it the other way around? Both situations are associated with increased overall survival. And in this classic study by Brian O'Sullivan from the University of Toronto, the rates of local control were actually similar using both pre-op and post-op radiotherapy. What they showed was that pre-op radiotherapy was associated with more acute wound complications, while more late treatment-related side effects were associated with post-op radiotherapy, probably because of the higher radiation dose and the larger treatment volume. So, is there a role for lymphadenectomy? Yes. It may provide long-term survival benefit for patients with isolated lymph node involvement, and it is recommended at the time of primary surgery. What about for unresectable disease? Maybe we can try different modalities before some of these tumors may actually become resectable with acceptable functional outcomes. And I'd like to show you an example of this. Here you have a patient with a large recurrent soft tissue sarcoma after inappropriate surgery. And he really was already scheduled for above knee amputation, and everyone had agreed to it, including our team plus the self. So the patient undergoes preoperative chemotherapy, and he was seen by our medical oncologist in the team, Dr. Fernando. And lo and behold, after treatment by Dr. Fernando, the tumor practically disappeared. On physical examination, you could hardly palpate it, to such an extent that the patient now began to think about the possibility of limb salvage surgery. So what we did was we repeated that MR, and we actually saw a much smaller tumor. However, the tumor still was pretty close to the popliteal vessels and the common peroneal nerve. Now, considering the dramatic response to preoperative or neoadjuvant chemotherapy, we decided to go ahead with limb salvage surgery with planned close margins. So we were able to resect the tumor off the common peroneal nerve and also off the popliteal vessels. And here you see the tumor removed with the vessels and nerve intact. And we plan to give chemotherapy and radiation therapy post-operatively. So let's take a quick look at the issue of inadvertent excisions or WOOP surgeries. How often have you heard surgeons tell you, we shelled out the lump, we got everything out, only for both surgeon and patient to be surprised and distressed when the pathologist reports that the lesion they thought was benign was in fact malignant, and that's why it's called WOOP surgery. And why does this happen? Soft tissue sarcomas are rare. For every 100 benign soft tissue tumors, you probably get only one soft tissue sarcoma. So the level of awareness is very low. The incidence of inadvertent excisions in literature is 33%. In our study, we showed more than half of our referrals were actually WOOP surgeries. And these are usually undertaken by frontline doctors, especially general surgeons. In our situation, almost 60% were from surgeries by these frontline doctors. Very often, there's no imaging, no biopsy, and some cases are not even sent for pathology. And they're very often associated with inappropriate approaches. So you have transverse incisions, inappropriate drain placements, multiple incisions, resulting in more operations, more reconstructive surgeries. Many patients coming to us with residual tumors and therefore a higher rate of local recurrence. The total cost of an inadvertent excision is double that of standard care at the tertiary center. And you have higher indirect costs, longer hospital stay, patients staying away from work, including those who are taking care of them. And all of these have to be interpreted in the context of a low to middle income country setting, like ours. So we want to raise the alarm about this increasing number of inadvertent excisions for soft tissue sarcomas. And we saw a rise even during the pandemic lockdown. So we've undertaken a 3-year study, which we entitled Addressing the Problem of Unplanned Excisions of Soft Tissue Sarcomas of the Extremities. The first year to define the problem, and we're actually almost done with it. The second year to undertake an educational campaign around the country. And the third year to do a prospective study to judge the success of this campaign. This is patterned after a UK NHS-sponsored educational campaign. And national guidelines were sent to all the GPs, stating that any patient with a lump that is bigger than 5 centimeters, increasing in size, deep to fascia, and painful should be considered a sarcoma and referred to a sarcoma unit. This actually showed a decrease in the total number of WOOP surgeries that they have been experiencing. So, in summary, this is an outline. We looked at the general principles, workup issues related to surgery. We defined surgical margins. We took a look at when we do amputations, the role of radiation therapy, recommendations for surgery, plus minus radiation therapy and chemotherapy, the role of lymphadenectomy, what to do with unresectable disease, and the occasional, not occasional, but the problem of inadvertent excisions or WOOP surgeries that we are seeing more commonly today. So again, congratulations to the AOS and congratulations to the organizers. Thank you very much for listening.
Hello, everyone. I'm Dr. Tom Chen from National Taiwan University Hospital. I'm a medical oncologist whose specialties are sarcomas and breast cancer. Today, it's really my honor to be invited by the Asian Oncology Society for the first international conference of the Asian Oncology Society meeting to talk about the new developments in the systemic therapy of soft tissue sarcomas. Here are my conflict of interest disclosures. To start with, I would like to bring your attention of the most recent WHO classification of soft tissue and bone tumors. With the help of our pathologist colleagues, we can see now there are more than 80 histologies of soft tissue sarcoma now in their classification. But clinically, how does this help us to treat our soft tissue sarcoma patients? I think even in terms of chemotherapy, histology matters in our selection of systemic treatment decisions. Although I think most of us do know that anthracycline plus or minus ifosfamide are suitable for most of the soft tissue sarcomas, there are some combination regimens that may be better fit for specific sarcoma subtypes, such as the combination of doxorubicin plus dacarbazine for leiomyosarcoma patients, single-agent paclitaxel for angiosarcoma patients, the combination of gemcitabine and docetaxel for leiomyosarcoma patients, eribulin for liposarcoma patients, trabectedin for leiomyosarcoma and liposarcoma, or probably in Japan, translocation-associated sarcoma patients, as well as a targeted agent, pazopanib, for most of the soft tissue sarcoma histologies, but inclusive of liposarcoma or rhabdomyosarcomas. However, today my talk is going to talk about the recent developments or advancements in the treatment of soft tissue sarcomas outside of immunotherapies. I'm going to first start with molecular-guided treatments for some of the soft tissue sarcoma subtypes, followed by mechanism-based treatment for soft tissue sarcomas, some of the subtypes, and lastly, what's the next step of the treatment advance for our soft tissue sarcoma patients. So I'm going to start with the molecular-guided treatment. I'll talk about 3 histology subtypes also associated with their targeted agents. So when I'm talking in this section, we're talking about there is a specific molecular feature in this subtype of sarcomas, and there's a targeted drug based on the molecular mechanism of this subtype. So I'm first going to talk about epithelioid sarcoma. It is a rare subtype of soft tissue sarcoma that commonly occur in the truncal and extremity area. Epitheliosarcomas can be classified as either classical, which mostly appear in the distal extremities, or proximal type, which mostly occur in the inguinal area or in the truncal area. Most of all, 90% or higher of patients of epitheliosarcoma had loss of a protein called INI1, and this is considered as a pathognomic diagnosis for epitheliosarcoma. Compared with other soft tissue sarcomas, epitheliosarcomas are typically less responsive to radiotherapy or chemotherapy. As you can see from the right-hand figure, no matter it's anthracycline-based or a Gemtax or pazopanib for epitheliosarcoma, the survival outcome is not good. The loss of the INI1 expression gives us an understanding of its mechanisms interaction between another oncogenic protein, EZH2. The loss of INI1 creates an oncogenic dependency on EZH2 because normally the INI1 or its associated SWI-SNF complex is functioning to suppress the function of the PRC2 complex, which uses EZH2 to activate gene expression regulation. So within epitheliosarcoma, this loss of INI1 would have a hyperactive EZH2 activity. And if we have an EZH2 inhibitor, it is likely that this tumor may not grow upon this inhibition. So in last year, in a single-arm phase 2 study, testing the first-in-class EZH2 inhibitor, tazemetostat, in epitheliosarcoma was reported at ASCO. Our site was fortunate to be enrolled into the study, and some of our patients did see some extraordinary responses from this single-agent treatment. As you can see for the waterfall plot, 51% of patients demonstrated reduction in target lesion diameters. So this is the single agent definitely showing some efficacy of this single agent for epitheliosarcoma patients. As you can see from the spider plot, patient who had responses has prolonged responses upon the single agent treatment of tazemetostat. As regard to the progression-free survival, the median PFS was 23.7 weeks, but as you can see from the orange arrow, for those who had not received any systemic treatment before enrolling in the study, the median PFS was 42.1 weeks. And also, in terms of the overall survival, the median overall survival was 82.4 weeks, around 50 months. But again, when you see the orange arrow, you can see that for those who had not received prior systemic therapy before enrolling into the tazemetostat clinical trial, the median overall survival was not reached, suggesting the tazemetostat has activity in epitheliosarcoma, especially for those who had not received prior systemic therapies. And in terms of the single-arm outcome, on January 23rd, 2020, the US FDA granted accelerated approval of tazemetostat for advanced epitheliosarcomas. A confirmatory randomized phase 3 study is currently ongoing to confirm the activity of tazemetostat in INI1 loss epitheliosarcomas. Now we're going to talk about a second cancer, the perivascular epitheliosarcoma tumor, or most commonly called PEComa. It is a mesenchymal neoplasm composed of histologically and immunohistochemically distinct epithelial spindle cells. Loss of tuberous sclerosis complex, TSC function, is common in PEComa. As you can see from the right-hand figure, the loss of TSC2 function will lose the suppression on RHEAP protein, and then the mTORC1 will be activated, following by the activation of downstream proteins such as S6. We mostly use the mTOR inhibitor everolimus or sirolimus to inhibit the PEComa. However, some PEComas are associated with other molecular features such as TFE3 translocation, and the efficacy of mTOR inhibition is less certain in this group of PEComa patients. As you can see from this report from Dr. Dixon reported in 2013, that PEComa patients who had TSC mutations were successfully treated with either sirolimus or everolimus mTOR inhibitors. Also, in last year's ASCO, there's a new formulation of the NAP sirolimus, which is an IV form of sirolimus, and this could mitigate the uncertainty of some of the oral mTOR inhibitors when taking the drugs. What they saw is a great activity with objective response rate of 42% with this single agent NAP sirolimus in the PEComa cohort. I think more important from this study is they did a biomarker analysis, and what they found was that responsive PEComa patients had either TSC1 or 2 mutation and activated S6 protein activation, suggesting that these responses are mostly seen only PEComa patients with either TSC1 or TSC2 mutations. So those who did not have TSC1 or 2 mutation PEComas may not respond to mTOR inhibition, suggesting that even for such a rare cancer type like PEComa, we have to understand its underlying molecular mechanisms to really find the best treatment option for our PEComa patients. And then the third is the recently very hot NTRK fusion genes. So NTRK fusions, it's encoding the TRK fusion proteins and are oncogenic drivers of a wide variety of adult and pediatric tumors, as you can see from this figure. There's no specific common partner for NTRK 1, 2, 3 genes, so sometimes this may be a diagnostic challenge for our pathologist colleagues. But today I'll not talk too much about the diagnostic challenges, but I'll talk about the activity of the NTRK inhibitors. At present, there are 2 NTRK inhibitors on the market. The first is larotrectinib, as you can see from this very fascinating waterfall plot, which was published in New England Journal of Medicine in 2018, that all solid tumor types that harbor NTRK mutations within these patients, more than 70% of patients responded very well to larotrectinib single-agent treatment. Also reported recently from entrectinib, which is another NTRK inhibitors, found a similar finding that more than 70% of the solid tumors that harbor NTRK fusion genes responded to the single-agent entrectinib treatment. For the sarcoma community, which data was reported by Dr. George Dimitri in CTOS, the Connective Tissue Oncology Society annual meeting last year, showing that within the sarcoma patients, no matter is infantile fibrosarcoma, soft tissue sarcoma with NTRK fusion genes, or wild-type GIST with NTRK fusion genes, we had a very impressive response with the treatment of larotrectinib. The duration of response was, median duration of response was not reached, and the median progression-free survival for this cohort was 28.3 months. That's more than 2 years. And because of the significant activity of NTRK inhibitors, but also with the rarity of the NTRK fusion gene presence, and I have mentioned the diagnostic challenges, recently, the World Sarcoma Network reported an opinion paper in the Annals of Oncology suggesting that when treating sarcoma patients, we should have priority to think about the diagnosis of NTRK testing priorities. The first priorities included the infantile fibrosarcoma or inflammatory myofibroblastic tumors, which are more likely to harbor NTRK fusion genes. The IMT tumors are those who are tested negative for ALK or ROS1 fusion genes. The medium priority include those sarcomas with complex genomics. There's no specific driver mutation identified yet, and wild-type GIST. Those with lower priorities are those sarcomas already known with recurrent fusion genes, such as the MDN2 amplified liposarcomas or synovial sarcomas, or GIST that already known with the oncogenic driver. So within this context, we may have a better chance and the resource to find out the NTRK fusion positive sarcomas to treat them with the NTRK inhibitors. After finishing the molecular guided treatment for 3 soft tissue sarcoma patients, we will have the second part as a mechanism-based treatment. What I mean by mechanism-based is that these subtypes did not have a specific oncogenic driver, but however, some of the mechanism-based studies have found benefit for treating of these patients. So first, I'm going to talk about desmoid tumor and the antiangiogenic mechanism. The antiangiogenic pazopanib, based on the phase 3 PALET study, has shown that compared with placebo, pazopanib does have a significant PFS benefit in most types of soft tissue sarcomas. However, in this study, desmoid tumor was not included. So what is desmoid tumor? Desmoid tumor accounts for 3% of all soft tissue tumors. The risk factors include FAP syndrome, pregnancy, and trauma. It is non-malignant, so somehow it does not metastasize, but its locally aggressiveness may comprise a lot of morbidity or even death when this tumor grows in the intra-abdomen. It is a locally aggressive mesenchymal tumor, and it occurs both intra-abdomen, abdominal wall, and extremity and truncal areas. Surgery or even observation is still the first opinion, but sometimes when surgery is not feasible or the tumor grows in critical areas, medical treatment is necessary. 2 years ago in New England Journal of Medicine, it was reported that the anti-angiogenic agent sorafenib, treated at 400 milligrams, which is just half the dose of those needed for hepatocellular carcinoma, has a significant activity compared with placebo for advanced desmoid tumors, as you can see from the Kaplan-Meier curve for the median progression-free survival and the waterfall plot from the sorafenib arm. You can see responsive patients being treated by single-agent desmoid tumor. Also, in the French sarcoma group, they had a study comparing pazopanib to a chemotherapy combination of vinblastine and methotrexate, showing that pazopanib also has significant activity in the treatment of desmoid tumor. Although desmoid tumors have known to have beta-catenin mutations, how this wind up with the angiogenesis is still not really uncertain. However, these clinical activities from these anti-angiogenic agents are very promising, and we still want to understand further how to connect better within the angiogenesis process and better treatment of our desmoid tumor patients. Secondly, is a novel mechanism of treatment for cancer types is activating the tumor suppressor proteins. So dysfunction of tumor suppressor proteins has been described in many sarcoma subtypes. The nuclear exporter could transport these tumor suppressor proteins outside to the cytoplasm, making it non-functional in the nucleus. XPO1 is a nuclear exporter responsible for the TSP transportation. So recently, there is an inhibitor of the XPO1, which is called selinexor. In its model, it has shown that intranuclear tumor suppressor proteins was increased after the inhibition of XPO1. In the phase 1b study for soft tissue and bone sarcomas, selinexor was found to have more potentially activity in dedifferentiated liposarcomas. 44% of dedifferentiated liposarcomas had durable response more than 4 months. So because of this preliminary activity, a randomized phase 2-3 study called SAIL was taken in dedifferentiated liposarcomas with selinexor. In 2018 ASCO, in abstract form, it was reported for the randomized phase 2 study that selinexor has a better activity in terms of PFS compared with placebo. And with this result, the randomized phase 3 study is currently ongoing. So we're very awaited for these results and hope that in the future, there's one more drug that we can use to help our treatment of our soft tissue sarcoma patients, especially for liposarcoma patients. So after these molecular-guided and mechanism-based treatment, what's the next step of treatment for advanced soft tissue sarcomas, especially for those who have complex genomics and there's no one fusion gene that's readily identifiable? I would take the example of angiosarcoma. So recently published in Nature Medicine by Dr. Panther, a patient-partner research approach using online engagement for angiosarcoma, the angiosarcoma project, is a good example of what we may need to expect in the future. Angiosarcoma is comprised about 2 to 3% of all soft tissue sarcomas, but they may come from any anatomical locations. They may come from the breast, or the cardiac, or in the lung, or head and neck, facial and scalp areas, or other cutaneous outer areas after radiation. However, when you account for the anatomical locations within the angiosarcoma cohort, as you can see from the arrows, the mutation landscapes was different. In the red arrow, which is mostly composed of the radiation-associated cutaneous angiosarcomas, MYC amplification is very common. However, in the blue arrow, where primary breast angiosarcomas was mostly found, what we saw was commonly a presence of PIK3CA mutation, which was not seen in other angiosarcoma subtypes. Furthermore, if we look into the tumor mutation burden, which I suppose Dr. Loong will talk about more in the immunotherapy section in sarcoma later, is that the head and neck, facial, scalp area of angiosarcoma has the highest tumor mutation burden as compared with angiosarcomas from other regions or anatomical locations. And this is exemplified by the responses to immune checkpoint inhibitors for angiosarcoma patients of the head and neck or facial, scalp, cutaneous areas, as you can see from the imagings. So when we want to develop further agents for our soft tissue sarcomas, we now may not only need to consider histology, but also different anatomical locations, because the underlying mechanisms of the molecular differences may be different. So we can find the optimal treatment for each of our soft tissue sarcoma patients. So in summary, the identification and target of specific molecular alterations in some soft tissue sarcomas have changed the treatment landscape of these subtypes, including epitheliosarcoma, PEComa, and tract fusion positive sarcomas. Mechanism-based treatments, anti-angiogenesis, nuclear export inhibitors, are also applicable to specific subtypes of sarcoma, although the more detailed understanding of the actual mechanism or biomarkers are future priorities. More detailed understanding of the molecular alterations of soft tissue sarcoma from different anatomical locations or etiology, even within the same histology, will provide new insights to more precision medicine-based selection for our STS patients. And I think that sums up my talk. I'm happy to answer questions. Thank you.
Hello, I'm Dr. Herbert Loong from the Chinese University of Hong Kong, and it gives me great pleasure to present to you my talk titled Emerging Role of Immunotherapies in the Management of Sarcomas. I'd like to thank the organizing committee of the International Conference of the Asian Oncology Society for extending this invitation to me. These are my disclosures. If I could start with the bottom line message, and that is presently there are no FDA-approved immunotherapy approaches specifically for the management of sarcomas. Of course, this excludes patients who harbor tumors with MSI high or TMB high status. However, there have been promising activity in several recent early phase clinical trials, and us treating physicians have certainly had anecdotal evidence of patients treated with checkpoint inhibitors with good responses. The aim of this talk really is to provide an overview of some of the recent immunotherapy trials, specifically checkpoint inhibitor trials in sarcomas, and also to discuss its future directions. So if we could take a look at this from a relatively systematic point of view, one of the approaches certainly is the use of a single agent checkpoint inhibitor. And certainly the pivotal immuno-oncology trial in sarcomas is the SARC-028 trial, which is the use of pembrolizumab in advanced soft tissue and bone sarcoma patients in a multi-center 2-cohort single-arm open-label study. This trial was run through the Sarcoma Alliance for Research Through Collaboration, or SARC group in the United States, and patients recruited into this trial had a maximum of up to 3 lines of prior treatment. Standard dose of pembrolizumab was used, and primary endpoint was investigator-assessed objective response. These are the results of the clinical trial, and certainly you could appreciate the fact that a small minority of patients actually had some evidence of response, whereas the majority of patients did not respond. However, in the minority of patients that did respond, they seem to have a relatively durable response with a 12-week progression-free survival of 55%. Interestingly enough, 6 out of the 7 objective responses were seen in patients with undifferentiated pleomorphic sarcoma or liposarcomas. Fast forward a couple more years, in the recent ESMO meeting, the French sarcoma group, presented by Dr. Jean-Yves Blay, presented their data of the use of pembrolizumab in selected rare sarcoma histotypes. Now, the design of this clinical trial, again, is an open-label phase 2 trial, but specifically, they are looking at rare disease histologies of sarcomas. And within the 81 patients recruited, there were a large variety of different histological subtypes, but the ones which were more common included chordomas, alveolar subpart sarcomas, desmoplastic small round cell tumors, as well as SMARC4 malignant rhabdoid tumors. Interestingly enough, there seems to be some benefit in some patients where the progression-free survival seems to be better in patients with alveolar soft part sarcoma, as well as chordoma. But we have to be very mindful of the fact that patients with alveolar soft part sarcomas are exquisitely sensitive to checkpoint inhibitors, as proven by prior clinical trials, and patients with chordomas may have a relatively slow tempo of disease. The bottom line is the fact that given the fact that this is an open label, single arm study with no comparators, it is very difficult for us to assess whether or not the pembrolizumab is really bringing an additional benefit. I think the billion-dollar question is, in the patients who did respond, who are these responders? Are we able to have effective predictive markers to respond to checkpoint inhibition in sarcomas? And the flip side is, if we don't have these predictive markers, are the potential risks of giving checkpoint inhibitors indiscriminately. Now here, within the slide, there are some known predictive markers in other malignancies for checkpoint inhibitors, including the establishment of immune infiltrates, the presence of aneuploidy, PD-L1 overexpression, as well as mutational burden. But whether these immune biomarkers have a specific role in sarcomas is still questionable. Assuming that those are the biomarkers we really want to look at, if we look at a real-world retrospective series of more than 6,000 sarcoma cases sent to Foundation Medicine, what they found is the fact that there is actually a large variation between different sarcoma histologies on the presence or absence of these potentially predictive biomarkers. And more importantly, there doesn't seem to be any concordance between high TMB or PD-L1 amplification or MSI status. Moreover, it is important to note that although it seems as though from this table or from this graph, there are specific histologies such as angiosarcomas with a high proportion of patients having a high TMB. If you notice the y-axis in this panel on the left, the upper range is only about 15%. So only 15% of samples of angiosarcomas actually had high TMB. And all patients with high TMB on the various histologies are actually outliers compared with the rest of the group. I think we also have to think about what are the risks of giving checkpoint inhibitors indiscriminately. And one of the potential side effects is the development of hyperprogression. Now, hyperprogression is defined as time to treatment failure of less than 2 months, or a 50% increase in tumor burden compared with pre-immuno-oncology treatment imaging, or a 2-fold increase in progression pace after the start of immuno-oncology drugs. Now, specifically in prior clinical trials or in prior studies, patients with MDM2 amplifications, as well as EGFR aberrations, appear to be associated with hyperprogression. And certainly MDM2 amplification is actually a hallmark of liposarcoma, as well as intimosarcomas. And such situations have been demonstrated in prior clinical trials, such as in the Alliance trial, where patients treated with single-agent nivolumab had presence of more than 100% tumor growth as their best response. The bottom line is the fact that we need effective biomarkers, and certainly without which we'll just hit a dead end. Maybe there is an effective biomarker around the corner. And in this recent publication in Nature, it has shown the fact that B cells are associated with survival and immunotherapy response in sarcomas. The French group, together with their Taiwanese counterparts, including Dr. Tom Chen, who presented earlier in this series of talks, have identified 5 distinct groups of soft tissue sarcomas based on the composition of the tumor microenvironment. Specifically, they've identified a group of B lineage signature immune high class, or class E, as shown on the panel on the right, which is associated with improved survival. They've also correlated this particular immune signature to the archival specimen of patients recruited into the SARC-028 trial. And interestingly enough, the responders to the single-agent pembrolizumab treatment were all patients within this particular class E immune signature. And more importantly, these patients also had an improvement in progression-free survival compared with patients with other immune signatures. So maybe this is something that is can be considered as a potential biomarker around the horizon. Short of this though, are there any other strategies or approaches that we can consider to improve the efficacy of checkpoint inhibitors? To begin with, maybe we could consider using a dual checkpoint approach, such as the combination of anti-PD-1 as well as anti-CTLA-4, or whether or not we could combine checkpoint inhibitors with radiation. Now, taking a dual checkpoint inhibition approach, I would like to bring your attention to the Alliance study, which was published in Lancet Oncology in 2018, where patients with advanced soft tissue sarcomas were treated with nivolumab with or without ipilimumab in a non-comparative randomized phase 2 clinical trial. Essentially, patients with advanced or unresectable sarcomas who's had more than one line of prior treatment with a relatively good ECOG performance status was randomized to either nivolumab and ipilimumab versus nivolumab alone. Now, patients who were recruited into the nivolumab arm had a chance of crossover upon disease progression to the combination approach. The bottom line is the fact that the overall response rate of either the monotherapy or combination is modest at best, although it does seem as though patients who were given the combination approach had a higher chance of having a response. More importantly though, patients who did develop a response in the treatment seem to have a longer duration of response if they were given the combination approach. However, cost really needs to be considered when we consider using these dual checkpoint inhibition approaches. And certainly, again, I think the same issue holds true with single agent checkpoint activity, is the fact that we don't have the good biomarkers to identify which patients will respond well. Now, another approach is to consider a combination of checkpoint plus radiation. And certainly the plan really is to harness the abscopal effect. What we do know is that radiotherapy leads to immunogenic cell death, and that can lead to the release of tumor antigens. These neoantigens are taken up by antigen-presenting cells, such as dendritic cells and phagocytic cells, and these APCs interact with tumor antigens and migrate to the lymph nodes. They present antigens to T cells and T cell propagation, and activated effector T cells leave the lymph nodes and home in on the tumors, both irradiated tumor as well as other metastases. And therefore, aside from the improvement in, or the potential improvement in the tumor that's being irradiated, there is a chance that this abscopal effect can also improve other tumors as well in the body. Now, this checkpoint plus approach for sarcomas, which includes the combination of checkpoint inhibition as well as radiotherapy, has been investigated. And at present, there are at least 2 active clinical trials looking at this. One being a smaller academic-driven trial, as well as one being a larger multi-group trial. Specifically, the larger multi-group trial is the SARC-032 trial, which is currently ongoing, which is the phase 2 randomized control trial of neoadjuvant pembrolizumab with radiotherapy and adjuvant pembrolizumab in patients with high-risk localized soft tissue sarcoma. Essentially, patients with grade 2 or 3 undifferentiated pleomorphic sarcoma or liposarcoma, which is more than 5 centimeters in size, and these two histologies were determined based on the original SARC-028 trial, having the two histologies with some response, were screened and consented for a potential treatment. Patients who've met the eligibility criteria are randomized into one of two arms. One is the standard of care arm, where patients are only given upfront radiation, followed by surgery and follow-up. And certainly in the experimental arm, patients, whilst given upfront radiation, are also given pembrolizumab every 3 weeks, followed by surgery, and then followed by adjuvant pembrolizumab. The primary endpoint of this trial is to look at disease-free survival, and the secondary endpoints includes local recurrence disease-free survival, as well as distant disease-free survival and overall survival. And we eagerly await the results of the study. This is very important, especially the fact that we are taking now immunotherapy in a neoadjuvant approach, and this is considered a window of opportunity study where we have the original biopsy specimen as well as the surgical specimen for translational research to improve our understanding in the potential synergism of checkpoint inhibition and radiation. However, this approach really also potentially opens a Pandora's box, and that is, since we have other factors coming into play aside from checkpoint inhibition, such as the use of radiotherapy, what is the optimal dosing strategy? What is the optimal dosimetry for radiation when we're going to give it together with checkpoint inhibitors? And what is the optimal dosing schedule for IO agents, given the fact that maybe you don't need to give it every 3 weeks and you could extend it for a longer duration between treatments and potentially lessen the side effects? Second question is, do you need dual inhibition of sarcomas at the expense of possibly more toxicities when we don't even know whether or not checkpoint inhibitors themselves are effective in these diseases? This neoadjuvant approach is very good in the sense that it gives us a window of opportunity. But on the other hand, would this put patients at risk of delaying definitive surgery if we ever run into complications in the combination use of checkpoint inhibitors plus radiotherapy? Lastly, again, with a lack of predictive biomarkers, we really don't know which patients are likely to benefit. In conclusion, at the end of the day, for sarcomas, it seems as though cytotoxic chemotherapy, as well as targeted therapy in a selected population, remains the backbone of treatment in patients with advanced soft tissue sarcomas. In the absence of easily reproducible predictive biomarkers, my suggestion is as follows. Number one, the role of single-agent checkpoint inhibition is uncertain, as evidenced by the results from the SARC-028 trial, as well as the recent trial from the French sarcoma group. A dual checkpoint blockade strategy may be more promising, and certainly checkpoint plus strategies, including the combination of checkpoint inhibitors plus radiotherapy, or potentially plus targeted therapy, including anti-VEGF inhibitors, should be further explored. The overriding aim, however, it really is the need to discover and establish reliable predictive biomarkers to rationalize the use of checkpoint inhibitors in this diverse group of diseases. With this, I would like to conclude and end, and I'm happy to answer any questions that you may have. Please feel free to send me an email or send me a message through Twitter, and I wish everybody best of health during the times of COVID-19. Thank you very much for your attention.
Good evening, everyone. This is Dr. Fernando. I am the chair for this live Q&A session, and I am being joined by Dr. Edward Wang from the Philippine General Hospital, Dr. Chen from the University of Taiwan, and Dr. Herbert Loong from the Chinese University in Hong Kong. So this is a live Q&A session regarding the sessions on sarcomas, and any questions that you would like to post, the chat box is open. So I'd like to begin this with a question first from Dr. Wang. You mentioned in your presentation that one of the projects that you would want is to educate the general surgeons and other frontliners out there on the proper diagnosis of sarcoma cases. And I'm interested in finding out how would you carry out that kind of project.
Well, it's not going to be a single person or a single institution project. This is going to be a project of a sarcoma consortium. So recently we formed the sarcoma consortium in the Philippines, maybe like 2-3 years back. And this is a concern for not just surgeons, but it's also a concern for other people who treat sarcomas, like the medical oncologists like yourself, the radiation oncologists. So it's a team effort, and we will go through it with lectures, with updates, webinars. An interesting thing, in the UK, they had a similar project, and they gave to physicians a golf ball, because the golf ball reminds you that anything bigger than a golf ball, you have to start thinking soft tissue sarcoma. So different things like that. Maybe you can give things to the general physician, the general surgeons, but it's going to be a year-long process, and it's going to be participated in by the sarcoma consortium. So it's not just going to be the surgeons. So you're going to be there, Dr. Fernando. Don't worry.
I expect that one. I have two questions for Dr. Chen. The first one deals with your statement that right now in systemic therapies, most likely our front line is chemotherapy, still going to be systemic chemotherapy. So in that regard, we know that there are very limited number of agents that we can actively use in sarcomas. So when we have a patient that has gone through to that, what would you recommend? And the second question is with regards to tyrosine kinase inhibitors and multikinase inhibitors that we're using as targeted therapies for sarcomas. Do you think, or are you? It is your opinion that they are mutually equal in their efficacy?
Yeah, so can I just make a clarify on the first question? You mentioned that, are you asking about resistant to first-line chemotherapy, or I didn't follow the last sentence, sorry.
No, the point is that since we're still looking at chemotherapy as our frontline choice in the systemic therapy, when you've exhausted all your chemotherapeutic agents, what would you recommend?
Yeah, so I think the importance actually I want to emphasize here is not only on drugs, but I think even in the metastatic setting or in the advanced setting for soft tissue sarcoma, a multidisciplinary team is very important. So a lot of times that we do run out of, like, you kind of run out of chemotherapeutic agents, but there are only like 1 or 2 sites of progression. And then actually in the multidisciplinary team, you can discuss with the surgeons or radiation oncologists whether the progression site could be treated, and then when you have some other parts more stabilized, sometimes you can have kind of persistent treatment. And outside of the chemotherapy regimens, I think we're more and more oriented to a histology-based treatment. So based on histologies, we know there are certain kind of agents, like for instance, angiosarcomas. They may be for the head and neck scalp angiosarcomas, they may be more likely to respond to immunotherapy, the immune checkpoint inhibitors, and of course, pazopanib is more of a standard second or third line treatment for other non-liposarcoma or non-rhabdomyosarcoma patients. So I do think that if at first you have this advanced diagnosis, it's a sarcoma NOS, and later on, when you want to think of other better treatments, you do have to get into the more specific histology that may be helpful in selection, or even like other like chemotherapy agents. The second question, with regard to the TKIs, I think there's still some differences, although they're all anti-angiogenic agents. For instance, they all have inhibition on the VEGFR1, 2, 3. But like pazopanib, they may be more focusing on the PDGFR alpha, beta, and lenvatinib. That's a clinical trial that we've been using with eribulin and soft tissue sarcoma. They have more potency on FGFR, and like regorafenib seems to have some efficacy in bone sarcomas, or even like there's an abstract with the small blue round cells, the chick fuse positive urine-like sarcomas. So I do think that although they're all targeting anti-angiogenic, I do think that there's somehow a little kind of subtle differences that may have more different outcomes on the different histology of soft tissue sarcomas.
Okay. And a question for Dr. Loong.
Right now, for most malignancies, immunotherapy seems to be the miracle treatment for many malignancies right now. How do you see the impact of immunotherapy in soft tissue sarcomas, given the fact that it's still not approved by most regulatory agencies for clinical use in that as that indication?
Yeah, thanks, Dr. Fernando. I think immunotherapy for sarcomas right now is still in its infancy, compared with other histologies. And specifically, I guess when we talk about immunotherapy, there's of course checkpoint inhibition, which probably is what we're really talking about most of the time. And there are also other types of immunotherapy like vaccines or T-cell therapy. And I think for sarcoma, we're entering into the latter field where I think there's a bit more promise. But specifically for checkpoint inhibition, at least based on the clinical trials, it really hasn't been all that sort of amazing, except for specific histologies such as alveolar soft part sarcoma. I think the problem, of course, is sarcoma is so heterogeneous. And in terms of the diagnosis itself can also be a challenge. So sometimes what we think is a particular type of sarcoma may not necessarily be true without doing the molecular tests and all the sort of slide reviews, etc. So based on just the normal sort of or run-of-the-mill markers, biomarkers for the use of checkpoint inhibitors, including TMB, MSI, or PD-L1 expression, in actual fact, most sarcomas are on the low side, or actually they're actually even non-existent. So I think there may be an avenue of using checkpoint inhibitors together with, say, radiotherapy, or maybe together with chemotherapy, and certainly there are some trials showing this, but just checkpoint inhibitors alone, either as a single agent or a doublet, doesn't seem to be all that promising.
You mentioned alveolar soft part sarcoma, and I think this is a question from the chat box that I can direct to the entire group. A question here in regards with alveolar soft part sarcoma. What would you recommend as treatment for a patient that has failed all of like 3 lines of multikinase inhibitor, androgenic inhibitors, but cannot afford treatment with checkpoint inhibitors?
Well, maybe I'll try to take that first. I would argue that number one, it's important to see which 3 types of TKIs were used, and sometimes there is the possibility of recycling through some of the TKIs. But having said that, I think if it's mainly just a financial issue, I think it's also important to know that checkpoint inhibitors, I mean, the recommended dosing is not, I mean, its efficacy isn't necessarily based on the recommended dose. So in actual fact, you would probably get away with some efficacy with a lower dose or even longer intervals between treatment because it's a monoclonal antibody. And certainly, when we first developed pembrolizumab and nivolumab, it was at a lower dose instead of a flat dose.
Yeah.
TKIs are also very expensive. So I would probably, actually, the first thing I'd do is do some calculations. You would probably realize that if you use pembrolizumab, for example, based on weight, as opposed to the flat dose of 200 milligrams, it's probably cheaper per month than prescribing any of the TKIs. And that probably already solves your question. And if they have exhausted the TKIs, I would really think that checkpoint inhibitors would be the way to go based on the clinical trials that we've seen and based on our clinical experience. I don't know.
Do you have anything to add there, Tom?
Yeah.
Yeah, I kind of follow Herbert's theme is that the immune checkpoint inhibitors, the dose, we still don't know what's actually the best optimal dose. I have patients who also have to pay out of pocket for immune checkpoint inhibitors, but put down very low dose of alveolar soft part sarcoma, but still responded as well. So I think in terms of budget-wise, this is a lot of times in Taiwan, a lot of physicians would discuss with patients that we're not giving at the recommended dose, but that doesn't mean that it's definitely not going to work. So I think that's something I would like to follow Herbert's thing. The other, I think, is for alveolar soft part sarcoma. Also, we already know it's quite chemo-resistant, but before TKI is available, there are also some cases suggesting that chemotherapy may work for probably 10% of these patients. So if there's really no other choices, and the patient performance status is okay, I still think that as the last resort, probably chemotherapy could be considered for all refractory treatment alveolar soft part sarcoma patients.
I think this is a corollary question and not necessarily alveolar soft part sarcoma. Ed, do you think in a sarcoma case that is refractory to systemic treatment, surgery could still have a palliative role?
That's going to be difficult. It really depends. because if you've got metastatic lesions and there probably is no purpose for the surgery except maybe on the rare occasion where you're treating the symptoms. If it's very painful, or it's causing big problems to the patient, but otherwise, they're probably very often mutilating surgeries in a patient who already has metastasis. So it's not something that we would recommend.
Okay.
It's not the usual. Yeah.
Okay. Finally, one last question, and I think this is something that the panel can discuss. Right now, in sarcoma diagnosis, the trend is towards next generation sequencing, and most sarcomas tend to have a molecular basis for diagnosis. But the problem is, we are in, for example, in our situation, it's a country in which such technology is still quite expensive. So, what would you guys propose as a backstop, or as a cover up, or as a stop between this, in order for us to bridge the gap into molecular testing for sarcomas?
Yeah, I can have my my thoughts first. So I still think that when we're discussing with our pathologist, I think histopathology is still the most important thing, even in the diagnosis of soft tissue sarcoma. So even with just H&E scan, they can still have limited differential diagnosis, and then followed by some immunohistochemistry. And if you really need to confirm some of the diagnosis, like for synovial or for Ewing, that you have different treatment options for them, then you can do the FISH. So it may take a bit longer time, but definitely less cost for targeting just starting everything with NGS. We know there's NTRK inhibitors out there, but still that's very limited. And I think a lot of sarcoma pathologists, they're doing their best to identify signals that may hint that it's more likely to be an NTRK fusion positive sarcomas. So I think still knowing, starting from the first, the histopathology and the architecture of the sarcoma would still kind of be helpful. I don't necessarily think that NGS is now for everything.
How about you, Herbert? What do you think?
Yeah, I mean, I agree with Tom. I think histopathology and the more traditional diagnostic workup is most important. Having said that, I think for NGS, I think one of the advantages is the fact that with sarcomas, we're still dealing with small numbers of patients in terms of population. So I think there's room for some collaboration or centralization of this work. And I think, within Asia, for example, we could certainly think of some referral centers where we could potentially send the cell blocks or even some unstained slides to have that done. So I think what that really needs is us getting together and forming this sort of network. And I'm quite sure there will be various companies or sort of academic endeavors where we could get grants for. And I think once we do that, and doing that, we'll also be training our pathologists at the same time, and they will bring their skills home. And now we're all Zooming and doing video conferences. Sooner or later, we'll be doing NGS on a video cam. So,
Well, I hope that does happen. And we're going to be pioneering our own project in NGS and soft tissue sarcoma, right?
Yes, we're going to start something like that. I mean, Ding knows our situation. I mean, it's not even NGS that's a problem. Sometimes our patients can't even afford to have the immunohistochem staining.
Yes.
So what happens is we get the pathology report from the H&E stain, and then the pathologist will ask the patients first if they can go through with the immunohistochem staining. So there's a segment of the population which cannot afford that. So I agree with Tom. I mean, it's still going to be very much the basics first. We're going to miss out on a few, I'm sure. But again, I also agree with Herbert exactly. I think this has got to be a collaborative work. I don't think any single country will have enough cases anyway. So at the same time, I think what the Philippines has quite a big number because of the big population. At the same time, we've got some cases which are more advanced. So we may be looking at some other things that may be of interest in the metastatic cases, in the more advanced soft tissue sarcomas. So I think when we collaborate, we can probably come up with something bigger.
You know, I agree. That would be nice. We could actually come up with a picture and let's say a molecular profile for Southeast Asia as far as soft tissue sarcomas are concerned. That would be a very good project to follow in the future, especially a collaborative project among several Southeast Asian countries. I'm being told that we're running out of time. Can I ask for some last words from our speakers? Can we begin with Dr. Wang?
Oh, yes. Thank you very much, Dr. Fernando, and to the AOS for this great meeting. I think you can see just on this screen, what I'd like to emphasize always is soft tissue sarcoma cannot be treated by a single specialty. It's got to be a team approach. And it's not very common. So you need collaborative work across hospitals, across teams, across countries, and we continue to learn from each other. So thank you very much for this, personally, a big learning experience for me too.
Thank you, Dr. Wang. Dr. Chen?
Yeah, so again, thank you for AOS and Dr. Fernando for inviting us to join this sarcoma session. It's very honored. And I think the AOS has been a very good job in the past few days, providing the most up-to-date and a lot of discussions about treatment. And I think in sarcoma, what I can say more is about, although we're talking a lot of, my talk is about like medical treatment advancement, but I think probably in the past decade, what's the most advanced in the multidisciplinary team involvement, just like Dr. Wang said. So I think I would recommend, every sarcoma treatment hospital to have more interdisciplinary collaboration, and also between countries to have more collaborative efforts toward this rare disease.
Yeah.
And finally, Dr. Loong?
Yeah, I mean, I echo both Dr. Wang as well as Dr. Chen's comments. And I think the bottom line is sarcoma is a niche disease, but it's generally around the world taken care of by friends amongst each other. Certainly, Dr. Wang, Dr. Fernando, and Dr. Chen, we've known each other for many years. And for our trainees who may be joining AOS and really listening to sarcoma for the first time, do join us in the battle against sarcomas, because I think it's a very fruitful experience and you get to hang out with the four of us. So.
And with that, ladies and gentlemen, I would like to thank you for sharing your time and participating in this live Q&A session. I will be closing the session now. Good night, and continue to enjoy the rest of the AOS. Thank you.
Thank you. Good
Bye.
night.
Good night, guys.
Good night.
Thank
Bye-bye.
you.
Bye, Tom.